check it.
Oh,
Yeah.
but make sure, please.
Yeah, the sound, because the sound is always right on here. Yeah, so you should be good. Yeah, you should be good.
Can y'all check on the thing to make sure everybody can hear it on?
They won't be able to on Blackboard because it's just recording on this, and then we're gonna have to upload this recording onto Blackboard.
All right. All right. Sorry about all that. So I am Dr. Cummings. I am a pediatric cardiologist in the pediatric department, and we will do a kind of beginning introduction to understanding ECGs. Most of you all, if you go into a clinical aspect, will have to do ECGs at some point. It is something that will try to help you out throughout each of your years, and you should hopefully feel at least somewhat competent by the time you start residency. So our outline today, what we're going to try to do is review the conduction system, look at ECGs and waveforms and intervals, as well as the leads. Then we'll be able to determine the heart rate, as well as determining the QRS axis. One thing I will say, and you will kind of hear me say every time you see me, is that the most important thing for you all to know now is to understand what normal is. Because at the very least, if you understand what normal is, you'll at least know that something is abnormal, and so you won't send somebody home to die. So you can at least make sure of that. So our first thing is looking at this normal conduction system. So the way the electrical impulses take place, there are, and you all getting this in anatomy, obviously, you have your internodal tracts. The impulse generally starts in the SA node, depolarizes the atria, goes down to the AV node, goes through the bundle of His, down your bundle branches, into the Purkinje, and then around to the Purkinje fibers. And that is how our impulses normally travel. So in ECG is an electrocardiogram. The K is because it was first done in German, and so cardio starts with K in German, but for us, ECG. It's a representation of the electrical events of the cardiac cycle. Each event has a distinctive waveform, and the study of which can lead to greater insight into the patient's cardiac pathophysiology. And it's important for us to kind of make sure that we break down each of those waveforms and understand each of them, and not what I've seen a lot of students do, especially when they get to the clinical years, is know what the letters are and they kind of jumble them together, and it then becomes difficult to kind of separate them out to make sure you know exactly what those things represent. So the types of pathology that we can identify and study from EKGs, obviously arrhythmias. So any insult to the electrical pathway can cause an arrhythmia. And there are also some arrhythmias that are actually normal. Myocardial ischemia and infarction, pericarditis, chamber hypertrophy, so the amount of electrical activity that is necessary to depolarize the muscle can depend on how large that muscle is. Then, of course, electrolyte disturbances, drug toxicities as well. So the things that most people at least will remember are the letters that come about it. And so we have our P wave. Does anybody know what the P wave represents? Say a little bit louder, but you just all yell it out, it's okay. Atrial depolarization. The QRS complex represents ventricular depolarization. T wave. I hear mumbling, but I can't hear y'all very well out here. Repolarization of what? Say it again. Ventricle, very good. And then U wave is actually the atrial repolarization you'll see sometimes as well. And then our PR interval, what is that? A little louder. So yes, but what it is basically the depolarization of the atria to the depolarization of the ventricles, that period of time. And so the thing that you want to make sure you're also understanding is that obviously when we're looking at this graph, the ECG is on, you can see the graph paper that it has, remembering that what our Y and our X axis are, our Y axis is going to be our time, right? So it's going to be duration. So this is the amount of time it is taking for these things to take place. And these intervals are important because when these intervals are abnormal, that is actually telling us what is taking place. And then because we are able to understand why these things are taking place, it then helps us to understand what will then take place with the heart. So the QT interval, which is going to be our depolarization and repolarization of the ventricle, if that takes too long, then you are now setting yourself up for an arrhythmia because when electrical activity takes place, we have refractory periods. And if something takes place during a refractory period, it can mess everything up. And that's what happens if you have long QT. That will be something we talk about a little later, but just understanding that the timing of these events is important because if it starts to become abnormal, you then are getting into dangerous areas for the patient. So the leads and electrodes are important. They're the things that measure the difference in the electrical potential between either two different points on the body or one point on the body and a virtual reference point with zero electrical potential located in the center of the heart. Now, that is a wonderful way of describing bipolar leads and unipolar leads. Does anybody know how many stickers we put on patients? I hear 6. I hear 13. I heard a 10. And I heard a 12. So you meant 12, not 13. Okay. So what type of ECGs are they called? They're called blank lead ECGs? 12 lead ECGs. So, but that does not necessarily mean that there are actually 12 leads. So do you know where we put them? So where we put them? Chest area. How many we put on the chest area? 6. Perfect. So that's V1 through V6. Y'all didn't expect to be answering questions today, did you? That's what it looks like. Yeah, when I was sitting in y'all positions, I used to go to sleep all the time with PowerPoints. It would kill me, so I decided once I got here I had to engage people. So I probably won't call on you all, but if nobody answers, then I'll start pointing people. So 6 on the chest. So that's V1 through V6. Those are our unipolar leads. Where else do we put them? Arms and legs. So limbs. So we have limb leads. How many limbs do we have? 4. Perfect. So there are 4 limb leads, 6 chest leads. How much is that? All right. So it's important to know, because I'll tell you once we get into rotations, people forget that. It's not 12 stickers that you're putting on. You're actually putting on 10. And actually only 9 of those stickers are actually bringing about information. One of them is what we call a grounding lead. So when if we have electricity, we always have to ground it. And so we have to have one of those as well. So the reason we have unipolar, so those 6 unipolar leads, and then we have bipolar, so 3 bipolar leads. So that ends up with how many leads that we are going to read on the ECG? Well, bipolar, I shouldn't say that. How much information will we get from that? So 6 unipolar gives us 6 points of reference. The 3 bipolar gives us also 6 points of reference. So that's how we end up getting our 12 lead ECG. Does that make sense? Yeah? Say that again? So those are our limb leads. So our left leg, is the one that is grounded. Then, and we'll talk about this more about how you know that. Then you will have AVF, AVL, and AVR. And those stand for augmented vector left, augmented vector right, augmented vector foot. So those 3 end up giving you then AVF, AVR, and AVL are gotten off of lead 1, lead 2, and lead 3. So where we put those stickers gives you 2 leads each. And we'll show that in a second. Here you go. So our EKG leads, we'll have our standard EKG has 12 leads. So we have our 3 standard limb leads, our 3 augmented limb leads, and those are the augmented vector ones. And there are 6 precordial leads. That's V1 through V6. And the axis of the particular lead represents the viewpoint from which it looks at the heart. The way I've always kind of described it since I got here is if I were to place people in different positions outside of Meharry or around the campus, but I knew exactly where you all were, and we were communicating, say, through, on the phone. If I wanted to know which direction an ambulance was coming, if I had everybody who was situated around the campus describe to me what they saw with the ambulance, if I knew where everybody was, I then can be able to determine which direction that ambulance is going. So if one person is sitting in a place and say, I see the back of the ambulance, another person says, I see the side, another person says, the ambulance is coming towards me, if I know where everybody is, then I can then make a good educated, when I educated this, I guess, I know exactly where the ambulance is coming from. And that's what these leads are doing. We know where we put the leads. The leads then give information about what the impulse is doing as represented by that lead. So the lead sees it coming towards it or the lead sees it going away from it. That would make a difference on what that ECG looks like. So going away is going to show a negative deflection. Going towards a positive deflection. If it's perpendicular, it'll be flat. But all of those things, since we know exactly where that where that lead is, we can then look to say, I know which way this direction is going. This is a normal thing or this is not. Does that make sense? Okay. So this triangle here is going to kind of be important. And this is kind of how things started and how they started figuring out how to use the ECG. The heart sits in the middle of the body or the chest. And so the heart will then sit in the middle of this triangle. And you can see here you have the left arm, you have the right arm, and you have the left leg. Can't remember. Right leg is the one that's supposed to be ground. Left leg is supposed to be foot. I can't remember if I said that or not. But you can see above, can I use this? Do you all see this? Yes, good. All right. So you can see 1 is all of this, 2 is this, and 3 is this. When we get to later, you will see that AVR represents this area. AVL represents this area. AVF represents this area. So AVL being left, AVR being right, AVF being foot. And I'm not sure if you knew, but you remember we had P, Q, R, S, T, and then U are the letters that we use. The reason they use those letters out of the alphabet is those are the letters that are in the center of the alphabet. The heart is in the center of the body. That's what they decided to do. So our standard limb leads, these are the vectors of the axis that we're looking for those limb leads. So 1 should be at 0 degrees. 2 should be at 60. 3 should be at 120. This, I'll show you in a second, is what we call normal axis. If we have an axis in between 0 and 120, then you're going to be in the normal axis. You'll understand how that is important later on. But I just want you to understand how we are now graphing the vectors of the impulse. And so remember, we have the heart in the middle of that triangle. The heart is going to be situated right here in the middle of this Y and X axis. And the impulse is then going to be traveling in the heart in these directions. This helps us to understand if the impulse is traveling correctly or there's something that's causing the impulse to go in a different direction. Our augmented limb leads, the direction of those is going to be different. So AVR, remember, is going to be towards our right side. AVL, again, is going to be on the left. Does anybody know what is important about the high right side of the heart? Right part of the heart, I should say. Say it again. So the right atrium is there. What is in the high right part of the right atrium? That was a whole bunch together. Give me one more time. The SA node. Why is the SA node important? Right, so that's the pacemaker of the heart. So we want to make sure that we know that what is representing where the SA node is around where AVR is. And so from that, if you remember what I talked about maybe 2 slides ago, if we look at AVR and we expect this to be a sinus rhythm, what direction should the impulse look like from AVR? Positive or negative, we'll say it that way. What direction should the impulse in AVR. So if we look at AVR on the ECG, you'll have waves that are either positive or waves that are negative. And there are two waves that are important. I'll talk a little bit about this a little later. P wave and QRS are the important ones to help us with our vectors and our axis. The P wave represents the atrial axis. The QRS represents the ventricular axis. If it is traveling away from AVR, that means it's leaving that area and going away from it, right? So it should be negative, right? So if you're going to look at an ECG and you look at the P wave and you go to AVR and it's positive, automatically that's an abnormal ECG, okay? AVR should not be positive. The QRS, sometimes, but definitely the P wave. If the P wave is a positive P wave, then something is wrong. So these are all the limb leads together. So you got 1, 2, 3, AVR, AVL, AVF. Sorry, I'm doing my head. 1, 2, 3, AVR, AVL, AVF. Okay? So our precordial leads. This is where these are placed. So to go back to where we place the limb leads, I think I talked about it. I'll come back in a second. So precordial leads, where we place them. So the midclavicular line is important. The angle of Lewis is actually where the xiphoid process, the sternum meets, has a little notch at the bottom of it, okay? And it's where the manubrium is. So you'll feel that. That's where you kind of start with. And then you go to the midclavicular line, and you'll go down right below the nipple is how you get V4. V2 and V3, you'll see once you go from the angle of Lewis, you'll count 1, use my finger. From the angle of Lewis, you'll go over. That will be your second rib space, then third, fourth, and then on the edge of each of those, you'll put V1 on the right side, V2 on the left. You'll go down to the midclavicular line below the nipple. You'll put V4. Directly in between where you had V2 and V4 is where you'll place V3. You'll then go to the mid-axillary line, which is right down to here. You will then put V6. Directly in between V4 and V6 is where you will place V5. Yes. I mean, you can put them on any way you want, but in order for you to actually get where V3 and V4 are, V5 are, you need to have V1 and V2 spaced and V6 placed, so you can know exactly in the midline where you're going to put it. And so by looking here where the you put the leads, if you see now coming kind of straight down through the skull, looking down into the body, so this is the spine back here, you will see why each of these leads sees what it sees, right? So the septal area, this right here, V1 and V2 are going to pick up well. The anterior portion of the heart right here, V3 and V4 will pick up well, and then the lateral wall is where V5 and V6 will pick up. This becomes very important when you are even more important if you're in adult cardiology, where people are having heart attacks all the time, and you need to know exactly where that ischemia is being shown. So our leads again, bipolar 1, 2, 3. They're standard limb leads. So the limb leads themselves are bipolar, but the 1, 2, 3 are what are giving you the two leads there. And then you have AVR, AVL, AVF, your augmented limb leads, V1 through V6. Okay? And the arrangement of the leads on the ECG. So if you look at the ECG, you'll see on the first column 1, 2, 3. Next column, AVR, AVL, AVF, then V1 through V3, and then V4 through V6. So that's how it's going to look when you have a standard ECG pop up. The way people are then able to recognize when we're trying to diagnose where the infarction is coming from, where that MI is the anatomic groups on there. So now you will see 1 is lateral, V6 is lateral, and AVL is lateral, right? So it's those two across, I keep using my hand, I'm sorry, here and then here. Our inferior leads, 2, 3, and AVF, this area down here. Our septal leads, V1 and V2. Our anterior leads, V3 and V4. And then the lateral leads are, like I said, V5 and V6. Same thing, just kind of talking about what is important. So our anterior walls, this is where we'll see these things. Okay? Our lateral walls are here, and then our inferior walls are there. Say that again? 2, 3 and ABF. Yeah. And so if we see, I'll try to roll through this again, sorry. There, for the precordial leads, that's what you're going to see. But you will not see inferior because of where these are situated, and that's why 2, 3 and ABF is important. And again, remember, those are the ones that are the bipolar leads. So now, determining the heart weight. There are, it's actually another rule as well as a rule of 1500s, but we always thought that was it's the same thing in 300, just not using it the same way. So don't worry, you'll see the rule of 1500 as well. That one always seemed extremely difficult for me, and it seemed pointless to do it, so I don't like teaching it. And then the 10-second rule. The reason the rule of 1500 is we're not using the big boxes, we're using very small boxes. So if you remember how an ECG paper looks, we have those little boxes that are there. And each of those you can get 5 of those, and that becomes a big box. You'll see, I'll have a picture on it later. What we're doing with the rule of 300 is counting those big boxes and using that to be able to help us determine what the heart rate is. So we take the number of big boxes between neighboring QRS complexes. So usually what you'll try to do is find where the QRS, you'll see the R wave, 2 positive ones, as you're going along, counting where those QRSs are. And remember, each of those QRS complexes represents the ventricle depolarizing. So you'll go in between those and count the number of big boxes in between them. And then you would divide that by 300. Although fast, this method really only works for regular rhythms, because if I have an irregular rhythm, my R is no longer going to be doing this every time, right? My R wave is going to be here, and then spaced out, and then here, and then spaced out, and then here. And if I'm doing that, all I'm doing is getting the heart rate for that one beat, or those 2 beats. So you have to have a regular rhythm for you to be able to use this rule. So here we'll have, you see the very tiny boxes. They're 5 across, 5 down. That becomes a big box. So for this rate, you will count in between these, right? So here's 1, 2, 3, 4, 5, 6. 300 divided by 6, 50 beats per minute. And you can see, obviously, if this one had the QRS over here, you're not going to really be able to do that because it's changing the space and distance between the R waves. So again, you'll do the same thing. And again, not worrying about all these other things. We'll talk about this at the next ECG level, what this rhythm is, because this is an abnormal rhythm. But what you try to do is find the QRS complex closest to one of these lines here, so you can actually start at the beginning of a box, and then go 1, 2, 3, 4, right? So it's roughly 75 beats per minute. It's a little less, so it's probably like 72, but that's all you need for the most part to get a rough estimate of how fast this heart rate is going. What is this one? It's a little harder, right? But this is still the QRS complexes. This is actually ventricular tachycardia here. I should have told you. This is atrial flutter here. And so here again, I try to get closest to one that's closest to the line right here. 1 box. Close to 2 boxes, so 1.5. So that's 200 beats per minute. So the rule of 300s. That's another thing. It's very easy to kind of set it up. So I don't have to do any division anymore. I've done this long enough. But you'll start to know if there's 1 box, obviously 300 divided by 1 is 300, right? 2 boxes, 300 divided by 2 is 150. 3, 100, 4, 75, 5, 60, 650. So if you just then count how many boxes are, you already automatically know what it is. And that will make it even faster for you to figure out what that rate is. The 10-second rule, most ECGs are recorded in 10 seconds. So when you get that standardized page, it's usually 10 seconds of time. And so we remember, again, the QRS represents what? Ventricular depolarization. What is ventricular depolarization in the real world? What do we call that? Heartbeat. Perfect. So if I were to have a patient laying in front of me and I wanted to figure out their pulse, what would I do? How would I take their pulse? I know this sounds like it's like this that easy. Yeah, it is that easy. I promise you it is. I would touch their pulse, right? And then what do I do? Count what? 15 seconds, right? Let's say I counted for 10 seconds. What would I have to divide by? Oh, divide by, multiply, right? Multiply by 6, right? Then I tell you how long this ECG is? 10 seconds, right? And what do we say the QRS is? Which is another name for saying what? I think I heard it. The pulse, right? Every time the heart contracts, that's the pulse. Every time the heart contracts, it had to depolarize in order for it to contract. So that QRS is the depolarization of the heart, which means the heart just contracted, which means if I had my finger on their pulse, I would have felt the pulse with my finger, which means that all I have to do is count the QRSs, know how long that strip is, and then multiply, if it's 10 seconds, multiply by 6, and there's the heart rate. So the easiest thing to do is make sure that you have a standardized ECG and then count your QRSs. And that way you know exactly what that heart rate is. And this works for regular or irregular rhythms. So, what is the heart rate? I'm not going to make you count all this out, but all I would do is count each of these, right? This is also ventricular tachycardia. So 33 of these are across, multiply that by 6, 198 beats per minute. Because this ventricular tachycardia is not one that you can do the rule of 300s by usually. Well, this type, I shouldn't say that. This is this happened because of long QT. That's a whole other issue. But so it's going to be what's called torsade de point, and it's going around the point. So it's getting faster, slower sometimes. And so you can't do in this issue, in this instance, the rule of 300s because you'd have to do it for each 2 sets. And instead, I just count them all and figure out what it is. So we talked about this briefly, and I said we get back to it later. So the QRS axis. So this represents what the net overall direction of the heart's electrical activity is. Yes?
Sorry, can you show us how you do the calculation?
This one?
The 3 and 6,
So you count each of these QRS complexes, because each of those QRS complexes is the heart depolarizing, which means the heart is contracting. And so because the heart is contracting, if I had my finger on an actual pulse, every time you see one of those QRS complexes, you would feel the pulse, right? And so all I'm doing then is counting how many times I would feel the pulse in 10 seconds. This is how many times I see the pulse in 10 seconds. And then you multiply that by 6, right? So anytime you guys go to a clinic and they're like, all right, what's the heart rate? And you put your finger on the pulse, you look at your watch, you count it for 15 seconds, you multiply that by 4. If you decided I'm only counting for 10 seconds, you would multiply that by 6. That is exactly what you're doing here. You're just looking at the pulse as opposed to feeling it. Say that one more time.
The first one is not much like the, it's more rectangle, different than the others.
This one here.
Not the same, yes, the first one. To the left of that. The second one.
Where are you talking about? Here? Aha. I'm glad you said that. I haven't gotten to that yet, but we can talk about it now. This is perfect. This is extremely important. I was going to tell you how, I'll tell you now so I won't forget about it. But when you go around, there are going to be plenty of people who tell you this is the way you have to read ECGs. I do not believe in that at all. I believe whatever way is more comfortable for you, that's the way you do it. You just make sure you do that every single time. That way you won't miss anything. However, the thing that you have to do first, and I said this a couple times on purpose, is make sure that you have a standardized ECG. Because if this is not a standardized ECG, then counting for 10 seconds isn't going to work because it may not be actually 10 seconds that they're doing. This box here lets you know that this is a standardized ECG. So this rectangular box here is 1 box wide, 2 boxes high. We'll get into it later. Generally, you'll also see at the bottom some numbers. And that numbers will tell you the speed and voltage that is represented. It'll be 25 and 10. 25 millimeters, 10 millivolts. And that's what this box represents. The 2 boxes high is the 10 millivolts. The 1 box wide is 25 milliseconds. I'm not sure if I said it. 25 milliseconds, 10 millivolts. That is telling you that the speed of the paper is 10 seconds, and the voltages that are there are normal. The reason that's important is that the computer sometimes will try to assist you. It usually does not change the speed, but it will change the voltages. So you can see in V2 how high this QRS complex is, right? If this was, let's say this was a patient who came in and said, you know, a couple of weeks ago, last week I fainted, and they're like, oh, let's do an ECG. And it comes off, that ECG could look completely normal. However, if this box here was cut in half, what that means is that the computer was trying to make it easier for you to read. When it was not cut in half, the QRS complexes crossed over from V3 was all the way up to V1. So you would have this top of the R wave here up to here. And so sometimes the computer will try to make it easier for you to read it so it's not overlapping different leads, and they'll cut it in half. But if you don't pay attention to see that it's cut in half, you'll think, oh, this looks like a normal ECG, when in fact, the voltages have been cut in half. Remember I said earlier, the larger the heart is, the more electrical activity is needed to depolarize, so that QRS complex gets very wide or tall. You'll have very tall QRS, like R waves, or very deep S waves. And again, the computer can change that. So the first thing you want to check is to make sure that this is a standard ECG. The speeds can change. You can widen out that speed, or you can make it faster or slower. The reason you would make it make it slower is if you have somebody who is in SVT, which is supraventricular tachycardia, which we'll talk about later. It means that heart rate is really, really fast, like this, 198. In babies, a baby who's having something like this, their heart rate can get to be 250. So you're trying to read something that's 250, you're not going to see anything. But a baby who's screaming and crying can have a heart rate of 210, and that's completely normal. He just has sinus tachycardia. That's still very fast. So what you want to be able to do is slow it down. Can I actually see P waves in this? So when you slow it down, you'll be able to see, oh, there's a P wave, there's a QRS. So now I know this is actually sinus tachycardia and not this baby having SVT or some form of SVT. So that's why you would do it. Usually you do that on your own. But if you come upon something that somebody else did, you still want to make sure that it's standard. So that's what that box is for. So the QRS axis, again, represents the net overall activity, direction of the heart's electrical activity. And abnormality of the axis can give you a hint that the ventricle is enlarged for some reason. So if you have this really big heart, now it's going to take a different direction than it normally does to depolarize that area. Because now, say the left ventricle is larger than the right. So if you have left ventricular hypertrophy, it's going to have more swing to the left. The right's going to kind of be a normal, and because it has more swing to the left, that axis is going to start to be moved to a different direction, which is going to tell you something is wrong with the heart. Conduction blocks. So there are AV blocks, there are hemi-AV blocks, and those things will show you something looks different on the axis, and therefore it's making it go a different direction. Because if I have a block of the right bundle branch, then the left is going to get most of that impulse, so it's going to swing the axis directions, or the net overall direction of the electrical activity leftward, and I'll be able to look into the ECG and say, wait a minute, why is this direction not normal? Then I have to figure out what's going on there as well. So the QRS axis, so we said before, the normal axis, you can see where that is. We have our right axis deviation in this area here. I keep doing it. Normal axis here, right axis deviation is here. Left axis deviation will be up in this direction, and our indeterminate axis will be this way. Remember, going back towards where AVR is. So, and you can see negative 30 to negative 90 is left axis deviation, positive 90 to 180 is right axis deviation. So there are two different ways of determining the axis. We have the quadrant approach and the equiphasic approach. Again, we talked about this earlier, but remembering, if something is predominantly positive, it's generally going towards that lead. Predominantly negative, going away. If it's isoelectric, meaning either the same above or the same below, or flat. The flat is, I shouldn't count. Flat is really no impulse at all. Same above and same below, it's equiphasic, right? So it's perpendicular to that lead. So those are important in the quadrant approach, especially. And so what you're going to do is you're looking at the quadrants are, you can be normal axis, left axis deviation, right axis, and the indeterminate axis. And we're using this like one of those box charts we do in statistics. So you'll have lead AVF on top, lead 1 on the side. And these are, remember where we have lead 1 is the very first lead in the first column. AVF is the last lead in the second column. Okay, and those are the ones you're going to look at. The way that I learned this, which helped me the most, was forgetting this box and using my thumbs. All right? So I want everybody to pick up your thumb, or use your thumbs and put your pens down. So your left thumb is going to be the most leftward on the ECG. So again, remember, the first lead on that you're going to see, which is the most leftward lead, is going to be lead 1. So that's going to be your thumb, left thumb. Your right thumb is going to be the most right, and that's going to be the second column. AVF is the last lead of the first 2 columns. And remember, the first 2 columns are our limb leads, the ones we put on there. So 1, 2, 3, AVR, AVL, AVF. So that's what we're going to do. 1, top one, AVF, the bottom one. So we'll have those. So our right is AVF, our left is 1. Everybody got that? All right, so now, if I look at lead 1, and it is positive, the QRS or the P wave. And there are 2 separate things. Remember, we have our atrial axis and we have our ventricular axis. Right now we're talking about ventricular axis, but both of them you can do the same thing with. So if QRS is positive in lead 1, I look at AVF, QRS is positive in AVF. 2 thumbs up, generally that means what? 2 thumbs up means good. That's our normal axis, all right? So 2 thumbs up, we got good. If I look at my lead 1 and it is negative, I look at AVF and it's positive, what thumb is down? What thumb is up? So if that thumb is up, I have my right axis deviation. That make sense? Flip it. If lead 1 is positive, AVF is down, which thumb is up? Left. So I have my left axis deviation. If I have lead 1 negative, AVF negative, 2 thumbs down, it's really bad. For pediatrics, that means this baby might have hypoplastic left heart syndrome or hypoplastic right heart. So it's really bad. So we got to figure out what's going on. Okay? You can have some normals, left axis deviation. That's further on for you all, so don't worry about trying to figure that out now. But just know that there are some times that is actually okay for it to be left axis deviation. But for you all, left axis deviation is bad, right axis deviation is bad, indeterminate axis is bad, normal is only good. That'll change later on in your lives. Right now, you don't have to worry about that. So the quadrant approach, I think we just talked about this, yeah. So when you all go back and study it, you can kind of review to make sure you're understanding it. But that's why I like the thumbs. It made it real easy. I could look real quick, put my thumb up. Oh, that's left axis deviation. I'll have to start figuring out where the leads were and everything like that. But the thumbs are the exact same thing. If you have lead 1 on your left, AVF on the right, those are going to come out if you start using your thumbs with the same thing. So if you see a box like this on your test, you still can use your thumbs. Okay? So we'll use an example for the quadrant approach. So what is it in lead 1? Look at lead 1. Is that positive or negative? All right. Is AVF positive or negative? All right. What is this? Perfect. All right. Example 2. I'm trying to do it so y'all don't see the answer, which is at the bottom of it. You don't look up there. Just look here. 1 is positive or negative? AVF is positive or negative? So this is what? Perfect. What do you mean? Yeah, they're going to have that. But even if not, it should always have those, because you have to know that they did this right. Because another thing will happen, I should tell you all this. So again, why it's important to know, you see that box there again, that you have a standardized ECG. There's some ECGs that will come out straight. So for instance, in the clinic, I have an ECG machine that is this big. So it can't print out a full strip of paper like we've seen some of the ECGs print out. So what it does is it prints them out straight in a line. So we'll have lead 1, lead 2, lead 3, AVL, AVR, AVF, V1, V3, V6, straight in a line. So I still need to be able to say, I know lead 1 is the one I'm looking at, AVF is the one I'm looking at. But if you have a standard paper, then you'll have it like this.
Sorry, just a quick question.
It's okay.
I'm just not getting it. How do we know that lead 1 is positive here? We look at the top and what are we looking at?
So what you're looking at, again, is the direction of either the P wave, but in this instance, we're looking at the direction of the QRS. So the R wave here, and so I'll break it down like this for you. So the QRS is specific parts of this. And I should have said this earlier, so I apologize. The Q is this area right here. You see this little divot? That's the Q. This is the R, and then the down slope is your S. And so you don't have an S in 1. Here, you have an S. The S wave is what's going down. Here, you have an S. The S wave going down. AVR, remember we always want AVR to usually want to be negative because it's going away from the SA node. It's an S wave, right? The S wave is the downward deflection. So what I'm looking for is, do I have an R wave or do I have an S wave? But because we put them all together as the QRS, we say, is the QRS positive, a positive deflection, which means it's going up, or is the QRS a negative deflection? It means it's going down. So you can see here in 1, this is positive, going up. Here in AVF, it's negative. You can look at 2. This is more difficult, right? You have a positive deflection and a negative deflection. So this is more equiphasic. So the same amount that's above the baseline and the same amount that's below the baseline gives you equiphasic. If you have more above the baseline than below the baseline, it's positive. More below the baseline than above the baseline, it's negative.
But above the baseline is R, below the baseline is S.
Correct. And for the thing above the baseline is R, below the baseline is S, is what she said. All right. So, yeah, just to go through it again, you determine the lead that contains the most equiphasic QRS complex. Oh, so this is different. Yeah, so this is the equiphasic approach. So in this, you're going to now have to start looking at the vectors. So for the equiphasic approach, you're going to determine which lead contains the most equiphasic QRS complex. Remember, the most equiphasic means is closest to the same above the baseline and below the baseline. The fact that QRS complex in this lead is equally positive and negative indicates that the net electrical vector, which is the overall QRS axis, is perpendicular. Remember I said it's going to be perpendicular to the axis of that particular lead, which means the impulse is traveling perpendicular to it. So you're going to then examine the QRS complex in whichever lead lies 90 degrees away from the lead identified in step 1. So whichever one is, and this again, the reason that this is a little bit more difficult is you need to have your graph with you, or at least have the graph in your mind to know if I'm looking at lead 2, which one is 90 degrees from that. If lead 2 in our last one was the most equiphasic, I then have to remember which lead is 90 degrees from that. I'll show you what it is in a second. So as you get more and more comfortable with where those leads are, it'll be easier to remember. But now it's more difficult because you have to be like, I don't remember where it is. I have to go find that graph and look at it, which is why most people use the thumbs. So you examine the QRS complex in whichever lead lies 90 degrees away from the lead identified in step 1. If that QRS complex in the second lead is predominantly positive, then the axis of the lead then that axis of the lead is approximately the same as the net QRS axis, which means it's that direction. If the QRS complex is predominantly negative, then the net QRS axis lies 180 degrees from the axis of that lead. Much more difficult, right? This one you have to go over a couple times, but we'll show you again. So first we have to find where our most isoelectric lead is. I'm sorry, isoelectric. Isoelectric is the same thing. Equiphasic lead. I'm trying to keep my vocabulary the same. So which one is equiphasic in our lead? So look, is 1 equiphasic? Is 2 equiphasic? 3. A little bit more, they have a positive, it's more equiphasic than these, but it's still much more negative. AVR is not, right? AVL? AVF. So out of these, it would be between these two, and AVF is the most equiphasic, right? So remember, AVF is going straight to our foot, right? So 90 degrees away from that is going to be the positive flash, is going to be 1. So it's positive in that direction. Remember, 1 is our what do you call it? Our y-axis, right? And so the y-axis, I should have put the chart up here. You remember we had 1 going straight across, that was 0, right? So if one is going straight across and it's positive, that's what the axis is going to be. And so the reason that we use this is when we have to determine exactly what the axis is. We're not then concerned as much about, is this axis normal, is this axis left axis deviation or right axis deviation. Actually, after we figure out this is a left axis deviation, well, now we might need to know, and again, this is if you've gone into either pediatric cardiology, or adult cardiology, you need to know exactly where the axis is, because now we're about to go tell the interventionalist, or the, not the interventionalist, the, I can't think of the word, oh my goodness, pediatric electrophysiologist, where we're looking to figure out what the issue is with the electrical impulses. When they have to go map the heart, we need to know where they need to go look for it, right? And so this tells us exactly where that axis is, and so we know then we have an exact number of what that axis is. So that's what the equiphasic axis is used for, to be able to figure out exactly what the axis is versus is this a normal axis. Because remember, the normal axis is going to be a wide range. The right axis deviation is going to be a wide range. Does that make sense? This one might not make sense as much, but I just want to make sure you understand what the differences in using them is for. Does that make sense? No? All right. So if I am looking at an ECG and I want to make sure that this is a normal ECG, or I want to make sure that nothing is going wrong with it, I'm looking to make sure that the P wave's in the right place, QRS, all those things look normal. I do that. Everything looks good. I then look for the axis of the impulse to make sure that the heart is either situated correctly or that there are no blocks or anything in the conduction system. I then will do my thumbs to make sure that this is a normal axis. If I've done my thumbs and I say, wait, this is a left axis deviation, something is off, I need to then be able to figure out what exactly is the axis of this heart. Is this axis barely out of range? So let me go back and I'll show you instead of talking about it this way. Let me get back to it. Come on. We'll use it this way. So look, we're going to use this to show you where the numbers are, right? So remember, lead one goes all the way across, and I'm going to go back to it further, but I just want you to see where we're determining things. So that last example we used, the axis ended up being zero degree axis, which means it is sitting within the normal axis range. If this was a left axis deviation and I need to know exactly where it is, I'm going to use the equiphasic. So first thing I did was use my thumbs, right? And my thumbs showed me that there was the QRS was a negative deflection in AVF and a positive deflection in 1. So I now know I'm in left axis deviation range. If I need to determine exactly what that range is, I now have to use my equiphasic approach, right? Because that then gives me a different way of figuring out where it is on that range. Is it within the normal? Am I correct? Is it in the normal axis, or is it really in the left axis deviation area? Now, there are obviously, as we get further and further along in understanding how to read ECGs, you can directly pinpoint exactly what it is. But you're going to use more towards the equiphasic range to do that than you would do with just your thumbs, because your thumbs are giving you a range. Your equiphasic is giving you closer to the exact axis that is needed. You all don't need to know the exact axis that is needed right now, but you will, especially if you start, the further you get into clinical things. Somebody raised, yes?
So what if you have more than one equiphasic branch?
So then you have to figure out which one is the most. You will never have one more. So for instance, in what we looked at before, it's the most equiphasic. So here, 2 and AVR, right? This one would be 2. It's more equiphasic than AVR. Here, let's see if we have another one. AVF has a little bit of a positive deflection, but not much. 2 in AVF again. 2 is more equiphasic here. Here's another one. So in this one, we had 3 in AVF, right? AVF is more equiphasic than 3. It's closer to having the same amount above the baseline and the same amount below the baseline. So that's how you determine. So again, that's what you have to remember. Let me see if I go this way. That's better. There we go. Where is it? You saw it? Okay, cool. You look at the graph. I'll just say, look at the graph, and it'll help you see. All right. Oh, it's 9 o'clock. So I'm not going to make y'all go through these, but just, you can look here. The most equiphasic on this one is going to be lead 2. You can see positive, negative in 1, positive in 3, positive in AVF, negative in AVL, positive in AVR. 2 is the only one that has this little hump there. It's almost basically isoelectric. So you know that's going to be your most equiphasic. 2, AVL is going to be one, is right next to it. 90 degrees from it. That's going to be predominantly negative, so you're going to have your QRS axis to be around 150. And that's actually our last one. Good. So this one is more difficult to conceptualize, but what the best way of doing it is getting the graph that we have, and I will not show that graph to you all. Where is it? Uh-oh. Slow down. I went backwards. I didn't mean to do that. Let's see. It is right, oh, not there. What in the world? What I gotta do? Oh, sorry. Well, the graph that they have there, so it shows where 1 is, where AVF is, where all the limb leads are. We had that triangle. That's what you want to look at to make sure you see what is perpendicular to which ones. And so if you have that graph